going to get started again. And if you just joined us, you can get your parking validated with your license plate number up at the security desk, and there's sign-in sheets on all the rows. Okay, so the purpose of today's training is to establish a uniform training module for the support coordination agency's designated trainer and supervisors to use in conjunction with the support coordination training handbook. So the training module will be used for new support coordinators, supervisors, and trainers hired to serve the EPSDT targeted population as part of the 16 hours of orientation training. For existing EPSDT staff, including support coordinators, supervisors, and trainers, as part of the 20 hours of annual training and as reference material for support coordinators and supervisors.
A little bit bigger. So,
yeah. An electronic copy of the handbook was emailed out to each agency. If you ever need a Word document or a copy of the training material, you can just send me an email. And the PowerPoint presentation will be emailed out to each agency after completion of the training, along with clarifications of questions and answers. And the handbook contains more detailed information than is provided in this presentation. So the training today is going to be broken down into 3 parts. Part 1 is EPSDT Targeted Population. We're going to talk about services available to EPSDT beneficiaries, intake, assessment, and comprehensive plan of care, coordination of services, and other requirements. Part 2 is going to cover Medicaid managed care. And part 3, we're going to talk about post-public health emergency. Okay, so EPSDT stands for Early Periodic Screening, Diagnostic, and Treatment. Early for assessing and identifying problems early. Periodic, checking children's health at periodic age-appropriate intervals. Screening, providing physical, mental, developmental, dental, hearing, vision, and other screening tests to detect potential problems. Diagnostic, performing diagnostic tests to follow up when a risk is identified. And treatment, control, correct, or reduce health problems found. The EPSDT support coordination program was established as a result of a lawsuit, Chisholm versus LDH, to provide support coordination to those individuals who have disabilities or chronic health conditions. Okay, so EPSDT support coordination eligibility. Individuals on the developmental disabilities request for services registry, or individuals for whom the service is determined medically necessary with documentation to substantiate that they meet the definition of special needs. And the full definition can be found on the EPSDT fact sheet, which is Appendix P. Be under the age of 21 and Medicaid eligible. So Chisholm class members are Medicaid beneficiaries ages 3 through 20 who are on the developmental disabilities request for services registry are called Chisholm class members. And then we have legacy Medicaid or fee for service, which is traditional Medicaid for people who are not enrolled in a managed care organization or MCO for most of their health services. Chisholm class members have the option of staying in legacy Medicaid for their physical health services. And then we have the Medicaid managed care program. Healthy Louisiana is the way most of Louisiana's Medicaid beneficiaries receive healthcare services. The state contracts with managed care organizations that deliver these services through their provider networks. Some of the MCOs have a different network of doctors, hospitals, and other providers than traditional Medicaid. Some Medicaid beneficiaries only receive specialized behavioral health services and transportation services through their health plan. Chisholm class members may choose to have all of their health care through the health plan or only their specialized behavioral health services. This is called opt-in. If they're in the coordinated system of care waiver, most of their specialized behavioral health services and their CSOC services will be accessed through Magellan. Okay, so now we're going to talk about services available to EPSDT beneficiaries. Children and youth receiving targeted EPSDT support coordination are eligible to receive all medically necessary Medicaid services that are available to people under the age of 21. In addition, if they're on the Developmental Disabilities Request for Services Registry, they may be eligible for services through the Louisiana Developmental Disabilities Services System, administered by the Office for Citizens with Developmental Disabilities through the local governing entities, or LGE. Services through the Office of Behavioral Health are available for children and youth with emotional disturbances, and children and youth may be able to receive services through the school system or through early childhood education programs. Through Medicaid, children under the age of 21 are entitled to receive all medically necessary healthcare, diagnostic services and treatment, and other measures coverable by Medicaid to correct or improve physical or mental conditions, even if these are not normally covered by Medicaid for beneficiaries 21 or older. Persons under age 21 are entitled to receive all equipment that is medically necessary, and this includes many items that are not covered for adults. These services may be subject to any restrictions allowable under federal Medicaid law. And you can refer to Appendix F for an expanded list of services available to Medicaid eligible children under the age of 21. Okay, so some of the Medicaid services that we're going to talk about that may not be available to those ages 21 or older, or are only available under certain circumstances, are EPSDT support coordination, psychological evaluations and therapy, medical, dental, vision, and hearing screenings, speech and language therapy, occupational therapy, physical therapy, personal care services, skilled nursing, extended skilled nursing services, pediatric day health care, dental, hearing aids, eyeglasses, medical equipment and supplies, applied behavioral analysis, and any other medically necessary healthcare, diagnostic service, treatment, and other measures which are covered by Medicaid, which includes a wide range of services not covered for recipients over the age of 21. There are no fixed limits on the amount of services beneficiaries under age 21 can receive. They are entitled to as many doctor visits and as many hours and amounts of any other services as are medically necessary for their individual conditions. Medicaid offered services are more comprehensive than services offered through schools as part of a child's IEP. IEPs only cover services that help with a child's education. Medicaid outside of the IEP process covers services needed to help any other aspect of a child's life as well. Some Medicaid services must be prior authorized before the service can be provided. For a listing of Medicaid services, consult the Medicaid Services Chart, Appendix C, or go to the LDH website found there. And even if a service is not on the Medicaid Services Chart, it must still be covered if it is a service permitted by federal Medicaid law and is necessary to correct or ameliorate a physical or mental condition of a beneficiary who is under the age of 21. The EPSDT Support Coordination Training Handbook also provides detailed information about specific services. Okay, so parents of children with developmental disabilities are sometimes unaware of the services that may be available to assist them. Therefore, it is important for the support coordinator to be knowledgeable of these services and how to access these people. As a support coordinator, it is your responsibility to make suggestions for these services. Do not wait for the family to request a service. If you see a need for one of these services, inform the family and document their response. If the child may need additional services, but it is not clear, suggest appropriate evaluations to determine whether there is. I don't know how to make this little box go away. Oh, I probably just, there we go. Yeah. Okay. All right. Okay, if the family states they aren't interested in the service, accept that. However, feel free to remind the parent of the service again when the opportunity presents. A support coordinator develops a full list of all the services a beneficiary needs and then helps them get and coordinate these necessary services. Parents often do not understand aspects of the Medicaid system. Therefore, one of the primary responsibilities of the support coordinator is to follow through with the request for services until the prior authorization is either approved or denied based on medical necessity, and when approved, make sure the services are provided as authorized. Okay, so now we're going to talk about the different Medicaid services that are available. The first one is applied behavioral analysis, ABA-based therapy, behavioral observation, and reinforcement to teach skills, increase useful behavior, including communication, and reduce harmful behavior. It's based on reliable evidence of their success in alleviating autism and other related conditions and is not experimental. For Medicaid to cover ABA through a licensed provider, the person must be under the age of 21, exhibit the presence of excesses and or deficits of behaviors that significantly interfere with home or community activities, including aggression, self-injury, elopement, etc., be diagnosed by a qualified healthcare professional with a condition for which ABA-based therapy is recognized as therapeutically appropriate, including autism spectrum disorder, have a comprehensive diagnostic evaluation, or CDE, by a qualified healthcare professional, and have a prescription for ABA-based therapy services ordered by a qualified healthcare professional. And usually the prescription is kind of included in the CDE, so you wouldn't necessarily need a separate prescription. To find an ABA provider in your area, you can call the managed care organization of the beneficiary, and those contact numbers are on Medicaid Managed Care Appendix B. If a beneficiary wants to see if they qualify for ABA, contact the beneficiary's MCO and complete a referral for a clinical diagnostic evaluation. And for more information on ABA, you can contact the MCO or LDH directly and refer to page 11 of the handbook. Transportation services, there's non-emergency medical transportation, which is provided for Medicaid beneficiaries to and or from a provider for a Medicaid covered service, including carved out services or value added benefits when no other means of transportation is available. All beneficiaries may access this service through their MCO, and the transportation phone numbers are found on Medicaid Managed Care Appendix B. Children under 17 must be accompanied by an attendant. The only exception to this rule are for all females, regardless of their age, seeking prenatal and or postpartum care. If a child is to be transported either as a beneficiary or an additional passenger, the parent or guardian of the child is responsible for providing an appropriate child passenger restraint system. The transportation providers will not transport any child without the appropriate child passenger restraint system. With the exception of urgent transportation requests and discharges from inpatient facilities, arrangement for non-emergency medical transportation should be made at least 48 hours in advance. The 48-hour minimum does not include non-business days. Transportation must be provided in all parishes and to all eligible beneficiaries. If there is a need for special arrangements, such as lift-equipped transportation, the MCO must ensure that such arrangements are made promptly so that the beneficiary can obtain the medical services they need. The role of the support coordinator is to assist the beneficiary in arranging transportation services. Non-emergency ambulance transportation is transportation provided by grant or air ambulance to a Medicaid beneficiary to and or from a Medicaid covered service, including carved out services or value added benefits when no other means of transportation is available, and the beneficiary's condition is such that use of any other method of transportation is contraindicated or would make the beneficiary susceptible to injury. The nature of the trip is not an emergency, but the beneficiary requires the use of an ambulance. All NEAT trips will require a completed valid certification of ambulance transportation. The beneficiary's treating physician, a registered nurse, the director of nursing, a nurse practitioner, etc., must certify on the certification of ambulance transportation that the transport is medically necessary and describe the medical condition which necessitates ambulance services. And then we have the gas reimbursement transportation program. Louisiana Medicaid will allow family members or friends to become Medicaid funded transportation providers for specific family members through the gas reimbursement transportation program. The program pays the beneficiary's friend or family member to take them to medical appointments when certain conditions are met. Gas reimbursement providers may not reside at the same address as beneficiaries that they transport. This includes parents of children in the same household, and beneficiaries cannot be reimbursed for transporting themselves to appointments. To assist someone you are serving that may benefit from this arrangement, contact the beneficiary's MCO, and again, those phone numbers are on Medicaid Managed Care Appendix B. Okay, now we're going to talk about behavioral health services. There's the Coordinated System of Care, or CSOC. CSOC was developed for Louisiana's children and youth with significant behavioral health challenges or co-occurring disorders that are in or at imminent risk of out-of-home placement. CSOC offers an array of Medicaid state plan and home and community-based waiver services to children and youth in need of mental health and or substance use treatment who are deemed clinically and financially eligible. CSOC is an evidence-informed approach that enables children to successfully live at home, stay in school, and reduce involvement in the child welfare and juvenile justice systems. CSOC might be right if the child is 5 to 20 years old, has a mental health or co-occurring disorder, has a history of child welfare, juvenile justice, and or trouble in school, and is an out-of-home placement or at risk of being placed out of the home.
Not you.
And if you're on the Zoom, can you mute yourself, please? Which is defined as homeless, at risk of going to psychiatric hospital, therapeutic, foster care, etc. Partners play a very important role in the success of CSOC. CSOC intends to ensure that efforts on behalf of children and families are integrated across systems. CSOC is a family-driven process, therefore a referral should be made with the parents' or guardian's knowledge, consent, and participation. To make a referral for CSOC, you can call Magellan directly at the 1-800 number or call the beneficiary's MCO with the parent guardian present or on the phone. The MCO will ask initial risk questions and transfer the call to Magellan if the child meets criteria. Magellan will conduct a brief child and adolescent needs assessment to establish preliminary eligibility. If, based on the brief assessment, a child youth is eligible for CSOC, Magellan will refer the child or youth to a wraparound agency to ensure that a comprehensive assessment is completed, offer the child, youth, and the family an opportunity to participate in CSOC, and begin forming a child and family team. Regardless of CSOC eligibility, their managed care organization will ensure that the child or youth is referred to providers who can meet their needs. Children and youth enrolled in CSOC are assigned a worker called a wraparound facilitator. The child and family will work with the facilitator to develop a plan of care with a team of people. The plan can include services and supports to meet their behavioral health needs, as well as other needed services and supports that affect their well-being. CSOC enrollees may receive these additional services: parent support and training, youth support and training, short-term respite care, and independent living and skills building. If a beneficiary is part of CSOC, they can access their specialized behavioral health services by contacting Magellan. So on your plan of care and the service needs, if someone is in CSOC, that they'll all have a wraparound facilitator, so that'll be one service need. And then if they're requesting any of these additional CSOC services, you can list those separately. And we do have CSOC as one of the pick list options. Chisholm class members are enrolled in an MCO for specialized behavioral health services, including assessments, evaluations, and testing, individual, family, and group therapy, psychiatrist visits, and therapeutic group home. If a Chisholm class member is enrolled in the coordinated system of care, most of their specialized behavioral health services will be accessed through Magellan. And then we have mental health rehabilitation services, which include community psychiatric support and treatment. And then you've got multisystemic therapy, functional family therapy, home builders, and assertive community treatment, psychosocial rehab, and crisis intervention. So all of the ones with an asterisk require a prior authorization from the MCO. And then community psychiatric support and treatment and psychosocial rehab providers arrange the assessment necessary to obtain prior authorization for rehab services. And then for CSOC enrollees, they're going to access these services through Magellan, and services through Magellan do not require PA tracking by the support coordinator. So we have that as one of the reasons for not tracking that you can select on your service need. And then we have licensed practitioner outpatient therapies, which includes parent-child interaction therapy, triple P positive parenting program, eye movement desensitization and processing therapy. And for more information, you can visit laevidence2practice.com and refer to handbook pages 15 to 16. And then we have residential and hospital-based behavioral health treatment services, including therapeutic group home care, psychiatric residential treatment, and inpatient hospitalization. And then you can also get school-based behavioral health services. Medicaid also funds behavioral health services provided through schools or early childhood educational settings for children ages 3 to 21, such as regular kindergarten, public or private preschool, Head Start centers, child care facilities, or home instruction. To be funded by Medicaid, these services must be included in the child's individualized education plan. Behavioral health services, treatment, and other measures to correct or ameliorate an identified mental health or substance use disorder diagnosis may be provided by licensed mental health practitioners or Louisiana certified school psychologists and counselors. Okay, now we're going to go through physical health services. So the first one is EPSDT screening exams and checkups. Medicaid beneficiaries under the age of 21 are eligible for well-child checkups or EPSDT screenings. These checkups include a health history, physical exam. Oops. Started echoing on me. Okay, seems good now. All right, laboratory tests, including lead blood level assessment, vision and hearing checks, developmental screenings, autism screenings, perinatal depression screening, and dental screenings. Checkups are available both on a regular basis and whenever additional health treatment or additional services are needed. There are no limits on the number of visits that are medically necessary for the beneficiary's condition. In addition, an interperiodic screen can be obtained whenever one is requested by the parent or is recommended by a health, developmental, or educational professional, including a support coordinator, in order to determine a child's need for health treatment or additional services. When detected early, medical conditions such as lead poisoning, sickle cell anemia, developmental delays, nutritional deficiencies, and behavioral disorders consistently result in successful outcomes and cost-effective treatment plans. Primary care physicians are responsible for making appropriate referrals when needed based on the results of a screening. Okay, and then personal care services are provided by direct service workers and defined as tasks that are medically necessary as they pertain to an EPSDT beneficiary's physical requirements when cognitive or physical limitations due to illness or injury necessitate assistance with eating, toileting, bathing, bed mobility, transferring, dressing, locomotion, personal hygiene, and bladder or bowel requirements. Assistance is provided with meal preparation if the beneficiary is on a non-restricted or is on a restricted diet that differs from the rest of the household members and no family member is preparing the meals. PCS does not include medical tasks such as medication administration, tracheotomy care, feeding tube, or catheter requirements. Assistance with these tasks can be covered through the Medicaid's home health program, and you can refer to Appendix E for PCS rule information and for a comparison of PCS and home health services. PCS is not intended as a substitute for childcare needs or to provide respite care to the primary caregiver. A parent or adult caregiver is not required to be in the home while services are being provided to children. Personal care services must be prior authorized by Gainwell Technologies for legacy Medicaid beneficiaries or the MCO. The provider must complete a social assessment form, a daily time schedule, and develop a plan of care. A practitioner must complete an EPSDT PCS Form 90 to prescribe or refer the service and sign the provider's plan of care. The number of hours approved is based on assistance with the personal care needs that are covered through this program. There are no set limits to the number of hours a beneficiary can receive. The support coordinator should assure that the practitioner has all critical information before the services are prescribed. All prior authorization requests should include necessary documentation to support the medical necessity of the
Go
request.
there, I'm gonna take a picture of all of this.
And if you're on Zoom, can you please mute yourself? Okay, extended home health services. Extended skilled nursing, also known as extended home health, is extended skilled nursing services is nursing care provided to beneficiaries under the age of 21 or who are considered medically fragile. Extended skilled nursing services must be prior authorized unless the visit is less than 3 hours per day. A prescription is needed from the authorizing healthcare provider stating the number of hours requested and a letter of medical necessity justifying the reason for extended skilled nursing services. Home health services for children and youth are not limited in terms of frequency or duration, but are based on the medical need. And then skilled nursing, also known as intermittent or part-time, is for needs for less than 3 hours of nursing care per day, which can be prescribed by an authorizing healthcare provider and obtained without prior authorization for beneficiaries age 0 through 20. These services must still be ordered by an authorized healthcare provider and provided by a home health services provider. And then there's also home health aid services and rehab services, meaning they can get physical, occupational, and speech therapy in the home, an outpatient facility, an early intervention center or rehab center, or at the school. And all rehab services must be prior authorized. Okay, and then pediatric day healthcare serves medically fragile individuals under the age of 21, including technology-dependent children who require close supervision. PDHC facilities offer an alternative healthcare choice or supplement to receiving in-home nursing care. PDHC may be provided up to 7 days per week and up to 12 hours per day as documented by the beneficiary's plan of care. Care and services to be provided shall include, but shall not be limited to, nursing care, respiratory care, physical, speech, and occupational therapies, assistance with activities of daily living, and transportation to and from the PDHC facility. Physical, occupational, speech, and audiology services. For Medicaid to cover these at school, it must be part of the child's IEP or individualized family support plan. For Medicaid to cover these services through an outpatient facility in a rehab center or home health, they must be ordered by a physician and must be prior authorized by Gainwell. And you can check with the MCO to determine if that particular MCO requires prior authorization for the service. The support coordinator is to explain to the beneficiary family that Medicaid will provide medically necessary therapies in addition to the therapies received at school through the IEP. The support coordinator is to ask the beneficiary family if they want to request any medically necessary therapies now, or if they want to receive therapies on the IEP during the school's summer break. The support coordinator helps the family to determine the setting in which the child will receive the greatest benefit, and also helps the family by making the appropriate referral and coordinating the days and times of this service with other services the beneficiary is receiving and monitoring the delivery of the services. Medical equipment and supplies. Beneficiaries are entitled to receive any medically necessary medical supplies, equipment, and appliances needed to correct, improve, or assist in dealing with physical or mental conditions. This includes lifts and other devices to help the family deal with a child's circumstances, such as communication devices, and also some medically necessary dietary or nutritional assistance. Medical equipment and supplies must be prescribed by a physician and prior authorized by Gainwell, and you can check with the MCO to determine if the MCO requires prior authorization. Disposable incontinence supplies for children aged 4 through 20 based on medical necessity, diapers, pull-on briefs, and liners or guards may be covered. And you can refer to Appendix R1 for more information and the prescription request form for disposable incontinence supplies. Medicaid or MCO prior authorization unit may approve less expensive items that it believes will meet a beneficiary's needs. If so, the notice of denial should identify the item. The beneficiary can accept the less costly item and still appeal the denial of the item originally requested. However, they must not dispose of, destroy, or damage beyond normal wear and tear the less expensive item while the appeal is pending. You should consult with the beneficiary and the provider to see if the less costly item identified will work and help the beneficiary decide whether to appeal for the item originally requested. The support coordinator must explain appeal rights to the family and assist in the appeal if the beneficiary wants that help. And again, you can refer to Appendix F for an expanded list of available services. To ask about other available services, you can contact the Specialty Care Resource Line, the Beneficiary's Managed Care Organization Member Services Line, or the Beneficiary's Medicaid Managed Care Case Manager. Although a service may not be listed, if it is a service permitted by federal Medicaid law and is necessary to correct or ameliorate a physical or mental condition of a recipient who is under age 21, it must be covered. Persons under age 21 are entitled to receive all equipment that is medically necessary. This includes many items that are not covered for adults. These services may be subject to the restrictions allowable under federal Medicaid law. And then non-Medicaid services, many non-Medicaid sources of supports and services are available, such as through the OCDD local governing entities, including flexible family funds, individual and family support. And you can refer to handbook pages 24 through 25, and then Appendix G has contact information for all of the LGEs. Through the Office of Behavioral Health, we have local governing entities, community behavioral health services, child adolescent response teams, and those more information can be found on pages 27 through 28 of the handbook, and contact information for the community behavioral health services is found on Appendix I. And then services available through the school system. Each school system in Louisiana has a child search coordinator who can arrange for evaluations of children to determine whether or not the child has a disability and requires special education services. And you can refer to handbook pages 28 through 30, and then other community services. Home and community-based waivers for people with developmental disabilities. Most children currently receiving EPSDT support coordination services are on the Developmental Disabilities Request for Services Registry. There's the New Opportunities Waiver, which provides comprehensive home and community-based services for individuals 3 years of age or older. The Children's Choice Waiver, which provides a limited package of services to children under the age of 21. The Supports Waiver, which provides specific activity-focused services for those age 18 years and older. And the Residential Options Waiver, which offers expanded home and community-based services for individuals of all ages. And then all of the fact sheets for those are found in Appendix D1 through D4. Okay, Know the facts about Children's Choice. Children's Choice waiver opportunities shall be offered to individuals under the age of 21 who are on the registry and have the highest level of need. Services are capped at $20,650 per care plan year and can be used for medical care, home and vehicle modifications, caregiving assistance and support, and other specialty services. When the family chooses to accept Children's Choice, the child's name is taken off of the Developmental Disabilities Request for Services registry. Youth who reach the age of 18 and want to work may choose to transition to a supports waiver as long as they remain eligible for waiver services. Youth who continue in the Children's Choice waiver beyond age 18 will age out of Children's Choice when they reach their 21st birthday. They will transition to the most appropriate waiver that meets their needs as long as they remain eligible for waiver services. And if one of y'all's EPSDT support coordination beneficiaries accepts a waiver offer, we'll keep their EPSDT support coordination case open until the waiver is certified, and then we'll adjust the PAs. And you would use change target population as the reason for case closure. What happens at age 21? The beneficiary becomes ineligible for some services at age 21, including support coordination, EPSDT personal care services, extended home health, incontinence supplies, and other items or services that are not part of Medicaid services for adults. Inform the beneficiary of the change in Medicaid services and encourage them to obtain exams, dental care, glasses, durable medical equipment, etc., prior to aging out. The support coordinator should be aware of available services and make arrangements to transition the beneficiary to receive all services he or she may need in order to continue to live in the most integrated setting that is appropriate for him or her. The support coordinator should begin making arrangements for transition at least 6 months prior to the beneficiary's 21st birthday. The EPSDT transition strategy must be addressed in the additional information. So you can document that you're going to inform them of long-term personal care services, OCDD services, how to obtain the services they now receive, link to resources to receive those services, the change in Medicaid services on their 21st birthday, and encourage them to obtain exams, glasses, DME, etc. prior to aging out. Provider agencies may need to be changed if the current provider only services children. Available services may include OCDD services, including extended family living, supported independent living, and vocational and rehab services, long-term personal care services through Medicaid. Beneficiaries who are already receiving EPSDT PCS will be contacted by Conduit regarding LTPCS. The support coordinator should inform the family to expect notification via phone or mail, and they can also call the 1-877 number for additional information. Rehabilitation services may provide assistance with services needed to pursue short or long-term employment goals, including higher education. And then Office of Aging and Adult Services, the Community Choices Waiver, and Adult Day Healthcare Waiver. If they have a statement of denial from OCDD, such as those receiving special needs support coordination, they can call the 1-877 number to request to be placed on the OAAS Request for Services registry. Okay, so any questions about any of the different services available? Okay, so now we're going to talk about intake, assessment, and comprehensive plan of care. How to access EPSDT support coordination. EPSDT support coordination is available to all Medicaid beneficiaries under the age of 21 who are on the Developmental Disabilities Request for Services registry, or for whom the service is determined medically necessary with documentation from Medicaid to substantiate that the EPSDT beneficiary meets the definition of special needs, which is found on Appendix P. Beneficiaries may elect to receive or discontinue EPSDT support coordination at any time. Discontinuing EPSDT support coordination does not affect a beneficiary's eligibility to receive Medicaid services or their placement on the DD request for services registry. Beneficiaries may request to resume EPSDT support coordination services at any time by calling SRI toll-free at our 1-800 number and requesting support coordination for EPSDT. If an individual is not yet on the DD request for services registry, they can contact their local governing entity, and those phone numbers are on Appendix G. And if they receive a statement of denial from OCDD, they may still be eligible for EPSDT support coordination if they meet the definition of special needs. So if any of y'all's EPSDT kids ever get a statement of denial, let me know. We can talk about what documentation we can get together to submit to Tracy to see if they're eligible for special needs. And we would wait for the appeal process to be completed if they wanted to appeal that decision. Okay, so intake, you'll contact the beneficiary and or legal guardian within 3 business days of the referral to the support coordination agency. At that time, face-to-face in-home appointment should be set up within 10 calendar days to discuss what support coordination is and how it can benefit the individual. The individual should be asked about formal information documents they may have or can obtain prior to the CPOC. So if they are currently receiving special education services, you'll need a current IEP to receive CPOC approval. And if they are receiving pediatric day health care or extended home health, you will need a copy of those current plans of care. Okay, the support coordination choice and release of information form, which sometimes we call the linkage form, must be used to obtain all plans, evaluations, assessments, and documents that OCDD has developed or used in connection with its determination that the beneficiary is eligible for services through the Developmental Disability Services System, including the statement of approval. And you can allow OCDD a 5-workday turnaround, and you can refer to Appendix N for a sample copy of the support coordination choice and release of information form. Okay, Medicaid eligibility verification. The support coordinator shall use the Medicaid eligibility verification system to determine if the beneficiary is eligible and remains eligible for Medicaid. The support coordinator shall check for continued eligibility monthly. If the beneficiary becomes ineligible for Medicaid, they are no longer eligible for support coordination, and closure procedures shall be followed as identified in the support coordination training handbook. So just make sure you let them know that they can contact y'all directly within 6 months of case closure if their Medicaid is reinstated, and you can reopen it. If it takes longer than 6 months, they need to contact us at SRI, and it's going to be treated like a brand new linkage. They'll get a new linkage date. And we'll treat it like an initial CPOC. If y'all reopen it on your end, they'll get the same plan of care and plan of care dates. And just let me know if you reopen it so I can get the PA reissued too. Okay, at the face-to-face in-home visit, which is conducted within 10 calendar days of the referral to the support coordination agency, you're going to determine if the individual accepts support coordination and agrees with the contact requirements, including the required face-to-face meetings. The individual is often overwhelmed with everything they're being told in this first meeting. Do not expect the individual to remember everything, even if you are providing information in writing. Review this information as often as is necessary. The support coordinator must explain and review the following with the individual: the Medicaid services chart, services available to Medicaid eligible children under the age of 21, support coordination rights and responsibilities, the appeal process, the complaint process for filing a report against support coordinators and or legacy Medicaid providers, discuss with Chisholm class members their right to choose between legacy Medicaid and the Medicaid managed care program for their physical health services, the complaint process for filing a report against managed care organizations or Medicaid managed care program providers, HIPAA and confidentiality, referral to EPSDT screening providers if it's requested, and the availability of formal and non-formal services. Assessment must begin within 7 calendar days of linkage and prior to the CPOC meeting. Assessment is the process of gathering and integrating formal and informal information relevant to the development of a person-centered plan of care. Formal information includes medical, psychological, pharmaceutical, social, educational information, and information from OCDD. Informal information includes information gathered in discussions with the family and the beneficiary, and may also include information gathered from talking to friends and extended family. So the support coordinator is to obtain all assessments, evaluations, and documents that OCDD used to determine eligibility, the current IEP, the current home health plan of care, the current pediatric day health care plan of care, and any other assessments by professionals, including a Form 90, LRS, special education evaluations, behavior plans, etc., that are required to obtain CPOC approval. The support coordinator is to contact OCDD, schools, pupil appraisal, and healthcare professionals for necessary records, ask the individual about documents they have or can obtain from their school, and follow up on requests for records. The support coordinator may need to assist the beneficiary with arranging professional evaluations and appointments, including well child visits, EPSDT screening exams, and follow-up evaluations. The information provided as a result of these appointments could prove critical in the assessment that will be used to develop the beneficiary's person-centered comprehensive plan of care. The comprehensive plan of care is the support coordinator's blueprint for assisting the individual. The CPOC is developed through a person-centered planning process and is based on the comprehensive information gathered during the assessment process, which identifies the individual's preferences, needs, goals, abilities, health status, and available supports. The CPOC must be completed in a face-to-face in-home meeting with the individual's support team. The individual and the legal guardian must be present. So your support team is made up of the individual, the legal guardian, the support coordinator, and other people chosen by the individual that know them best, such as family, friends, other support systems, or direct service providers. All references to the individual include the role of the individual's representative. And then everyone present at the meeting must sign the CPOC participant signature page in the planning participants box. Competent majors determine if the beneficiary is a competent major. A competent major is 18 years of age or older and has not been legally declared incompetent. If the competent major is able to express their preferences, the support coordinator should talk directly to them and have them sign all documents. A competent major may choose to have an authorized representative by completing the authorized representative form, Appendix U. If the competent major is unable to express their preferences due to a disability for which an accommodation cannot bridge the gap, the support coordinator should document why they believe the competent major is not able to direct their own care and must obtain an authorized representative form or a supported decision-making agreement. And you can refer to handbook pages 32 through 33 for more information. The CPOC is based on the identified needs and the unique personal outcomes envisioned, defined, and prioritized by the individual. The CPOC must include agreed upon strategies to achieve or maintain the personal outcomes using appropriate natural community supports, non-formal and formal paid services. The CPOC must include timelines in which the personal outcomes can be met or at least reviewed. The minimum requirement is quarterly. And the support coordinator is responsible for providing complete and clear information to assure the individual can make informed choices regarding the supports and services they receive and from whom. During the CPOC meeting, the support coordinator must use the Medicaid services chart to discuss available Medicaid services. Do not wait for the individual to request a service. If you see a need for a service, offer the service to the individual and document their response. So your three options are the service is requested, the service is declined, or the service is on hold. So that should all be clearly documented in the CPOC for every service need that you think they could benefit from. If the individual may need additional services, but it is not clear, suggest appropriate evaluations to determine whether there is a need, and again, document their response. One of the primary responsibilities of the support coordinator is to follow through with requests for services. The CPOC is completed electronically in ELSIS, which is the Louisiana Support Coordinator Information System. The SC should review a blank copy of the CPOC and the instructions before conducting each CPOC. The CPOC is designed to briefly summarize important information so that it can be reviewed and considered in evaluating the need for proposed services and supports. Information relevant and applicable to justifying services requested by the individual must be provided. Information critical to the individual's health and safety should be documented in the CPOC, and it should always emphasize the individual's personal outcomes. The goal is to provide support and services in a person-focused, cost-effective, and accountable manner. Okay, so our plan of care has 6 sections: contact information, medical, social, family history, service needs and supports, CPOC participants, CPOC approval, and then a typical weekly schedule, which is a paper form. Okay, so section 1 is your demographics. The initial portion of the CPOC is self-explanatory and requires the SC to develop current contact information on the individual, including name, mailing and physical address, good contact numbers, social security number, Medicaid ID, ICD-10, etc. Nothing should be left blank. Next to the legal guardian's name, you can document the relationship. And then if the individual is a competent major, that will open up the, are they able to direct their own care box? So if the legal status is changed to competent major, you'll be able to answer that question. And then see the red print that says the Medicaid number does not match the Medicaid number on the most recent PA. If you ever need the Medicaid ID updated on one of y'all's support coordination PAs, you can send me a copy of the electronic Medicaid eligibility verification, and I can update that on the PA and get it recent. Any questions about the demographics? Okay, section 2 is the medical, social, family history. You'll interview those who know the beneficiary best, provide information about the past and current situations in the beneficiary's life and about their family. Information included is relevant to the beneficiary's life today and provides a mean of sharing social family history. If any information is unknown, document that it's unknown. If there's only sketchy information available in any health status area, remember that the beneficiary is eligible for screenings, which can help to determine his or her health needs. It is the support coordinator's responsibility to help the beneficiary access those screening services. In addition, it is important to remember that psychological and behavioral services are available for the beneficiary and should be offered. Always document the offer of services and the response received, and make it very clear if it's requested, declined, or on hold. So you have a past section for pertinent historical information. So if something happened over a year ago, you can move it to the past section. You're going to discuss anything significant with mom's prenatal health or the birth, the nature and cause of the disability if it's known, the age of diagnosis and who made it, any early intervention services received, any placement history outside of their current placement, like if they lived with a different family member, if they've been in foster care, any psychiatric hospitalizations, anything like that, past medical history, surgeries, or hospitalizations, and events that led to the request for services at this time. If there are no services to coordinate, is the family aware that support coordination is optional and declining will not affect their eligibility to receive Medicaid services or their placement on the developmental disabilities request for services registry? The present section will describe their current living situation and their natural supports. You'll include the names and ages of all household members. Discuss their family situation and social support network. Must address both parents and if they provide natural or financial support. Relevant social, environmental, and health factors that impact the beneficiary. If they have access to the community and transportation. The source of household income, which I don't need to know like specific dollar amounts, but if their parents are employed, if they're receiving SSI, any services that were offered, like Family Flexible Fund or anything like that. Any of their desires and requests and their educational needs. And then the medical diagnosis section is a brief narrative description of the person's health history, current medical condition, including medical diagnoses, hospitalizations, and continuing health concerns and medical needs should be included. So the first thing you're going to do is document what current formal documentation you have to support their qualifying diagnosis or diagnoses. So I'm generally looking for whatever their ICD-10 is in the demographics for you to state what current formal documentation you have to support that ICD-10 code. So usually it's just that the 2023 IEP, the primary exceptionality is developmental delay or autism or whatever their ICD-10 is. If any diagnosis is parent states and you don't have documentation to back it up, address what you're doing to obtain the documentation. And if no documentation exists, address if they want a referral for an evaluation. List all medical specialists, their name, their specialty, how often they see them, and the last or upcoming visit, identifying if they're overdue. And I've got an example there for you. So like primary care physician is seen annually. They were last seen in July of 2022. So they indicated that they're overdue for a visit and that the SC offered scheduling assistance, but mom declined and will schedule on her own. The dentist is seen biannually. Last was September 2023. Next is to be determined. A psychiatrist is seen annually, and then they've got their last and their next visit. And then an ENT is seen as needed, and the last visit was summer of 2021. And then you're going to list all medications and what they are prescribed for, and you can group any of those together if they have like a bunch of behavioral meds or seizure meds or whatever. Okay, then we're also going to discuss any concerns with their vision or hearing. Do they need eyeglasses, hearing aids? How do they communicate? If there's any if they're nonverbal, you need to identify any nonverbal ways that they communicate, like gestures, sign language, any assistive devices that they have. If they're verbal, like, are they fully able to communicate verbally? Do they just use a few words or short sentences or whatever? So try to be as descriptive as possible. Address ambulation and mobility. If they have full use of their arms, legs, hands, any issues with fine or gross motor skills, any assistive devices needed, like a gait trainer, wheelchair, walker, any toileting needs. Are they working on potty training? Are they fully incontinent? Any dietary needs, could be food allergies. Do their meals need to be cut into small pieces? Are they working on weight gains? Maybe they need Pediasure. Do they have a G-tube? Do they need assistance with their activities of daily living? And if so, was PCS offered? And if PCS is requested or received, what ADLs do they need PCS to assist with? What therapies do they receive at school, and were community therapies offered? What assistive devices or durable medical equipment do they have or need? And then any special procedures or medical equipment like G-tube, trach, catheter. How often is the special procedure administered? And with skilled nursing or extended home health, if that's an identified need, was it offered and what response was received? And then your psychiatric behavioral section is a narrative description of the person's psychiatric status, diagnoses, and significant behavior concerns. Address behaviors at both home and school. Describe the behavior. What exactly does it look like? How often do behaviors occur, and be specific throughout the day. An episode can last 15 to 30 minutes, daily, a few times per month, etc. Any significant behavioral incidents, document the month and the year and what exactly occurred. Any known triggers, what strategies are used, and how are the behaviors managed, and what behavior services were offered and which are received or requested. If the beneficiary has an autism or related diagnosis, or has even been labeled even informally as having autism, please make sure you are either connecting the class member with ABA or referring for testing to assess the need, or documenting that the family declined these services. If declined, please revisit ABA with the family at least annually. As you know, autism services can be most effective when delivered as early as possible in a child's life. Services usually should begin at ages 2 to 6. The needed early connection is thwarted if support coordinators fail to identify ABA as a possible therapy and arrange it unless declined. And then we have an evaluation documentation section where you will include the dates of any formal information documents that were used in the development of the CPOC. At least one current formal information document is required in the development of an annual CPOC, and current means that the formal information document was less than a year old at the time of the plan of care meeting. And you must have the following documents on file. So one thing that you're using is your current formal information document. And then if they're receiving special education, you would have the current IEP. If they're receiving extended home health, you would have the current plan of care for that. And if they're receiving pediatric day health care, you would have the current PDHC plan of care. And then you're either going to have a copy of the current statement of approval from OCDD, or you must have redetermination as a service need if it's expired or is expiring this CPOC year. And then if they're receiving special needs support coordination, that means that they have a statement of denial from OCDD. So that would be like the one case where you wouldn't need the SOA. And then make sure to enter either the expiration date of the SOA or check the permanent box. So I can still approve a plan of care with an SOA that's expiring. I'm just going to end the the CPOC end date will be the date that the SOA expires. And if you ever need an extension, you can just send me documentation from OCDD regarding the status of the redetermination and their need for more time. So you can just email your contact person at your LGE, ask for a status, forward that to me, and I can issue an extension while the SOA is in process. And then this is a screenshot of what the CPOC Section 2 looks like in ELSIS. So any questions about this stuff? Yes. I can find out and get back to you. Okay. Okay.
Send me that name and I'll get with Tanya Murphy. She go over the LGEs, but I think they're supposed to have 90 days, but I know they're behind. So just send me the names. So, yeah. That's the parent refuses to schedule the appointment, we have to have a current SOA to receive our services. So if they want to receive any OCD services, they have to make that appointment. This, you can just be point blank to them. Say, want our services? Schedule. I can get scheduled for you. Need to. Any other questions? Yeah.
Yes. Okay, so and while we're still on this little part, so common mistakes would be not giving me the names and ages of all household members. with the doctors, a lot of y'all don't document the last and next visit. So what I'm really looking for there is just if they're overdue for any visits, that we make that a service need, that we offer the scheduling assistance, we offer transportation, we offer any freedom of choice list that they may need if they need a new provider. So if someone doesn't have a dentist, is overdue for a primary care physician appointment, we want to make sure that that's a service need. If they're on any behavioral medications, that needs to be listed as a service need. You always have to document what current formal documentation you have and what diagnosis is on there. So that should be updated with every annual plan. These are pretty, and then like the main thing with the annual plans is just having inconsistent information. Like you have something in the medical diagnosis section, and then when you get down to the service needs, it doesn't exactly match up, or there's an update in the additional information section that didn't make it to the medical diagnoses. So I would just also suggest like not repeating any information, like just have it, like sometimes I'll see something in the past and then it's also documented in the medical diagnoses and in the additional information section. So if the family decides to decline PCS, you know, have 3 spots where you have to update it. So just try to keep it like current information in the medical diagnoses section, then like have a list going of all your service needs. And then in the additional information section, you can just kind of give me like a status, provider names, that kind of stuff. And then the other one would be you always have to document the offer of services and what response was received so that I know that that was addressed. So if they're nonverbal, did we offer speech therapy? If they're having problems with mobility, did we offer occupational or physical therapy? If they have toileting needs, did you offer diapers, dietary needs, Pediasure, G-tube, that kind of stuff? If they receive, so if I get down to the service needs and there's school speech therapy or occupational therapy, I'm going to make sure we offer that in the community as well. What assistive devices or DMEs do they have? If they have a durable medical equipment, that should also be a service need. And then behaviors, try not to use words like rarely or frequently, try to be more specific than that. Address behavior both at home and at school. And then again, the offer of any services or any services that are received, make sure those are documented. And then if they have autism or a related disorder, make sure ABA is addressed. Okay, so now we're going to talk about the service needs section. So there's a service strategy and a description box. You're going to document how the need was determined, if the individual requests to receive the identified need, and any reasons why not, the primary goal, who is providing the support, if the service requires PA tracking and the reason for not tracking any Medicaid service, and the amount of service approved. And again, the information in the service needs section should match what's in like the body of the CPOC. The support coordinator will coordinate all services, Medicaid and non-Medicaid, and ensure that the beneficiary receives the services they need to achieve or maintain their personal outcomes. When a service is requested, the support coordinator should provide the individual with the medical information forms that are required for the specific service. The support coordinator should assist with scheduling the doctor appointment, transportation, etc. as needed. If it is not a Medicaid service, the SC is to assist in locating resources to provide the service need. So you'll identify all services the individual is currently receiving and those services that are requested, both Medicaid and non-Medicaid, clearly identifying each service and the amounts approved. List every service need separately. So like you couldn't group school speech therapy and community speech therapy together. Those need to be separate service needs. Make sure to select the appropriate service from the service strategy pick list. And if you don't see that option, there's an other, and then you can just describe it in the description box. And that description box should clarify the service need that is requested, but please don't put the provider's name or use terms like requested, as this may change over time. So if there's like a change in service, you would update that on your tracking log, but you don't have to update that every time on your service need. So like you would just have PCS as a service need. If the provider changed, you would bring forward a change in service tracking log. Okay, and then everything you see in bold here is available on the service strategy pick list. So we have personal care services, home health services, which can be used for extended home health, intermittent nursing, or in-home speech, occupational, or physical therapy, medical equipment and supplies, which you can use for one-time DMEs like wheelchairs, hospital beds, or weighted blankets, and ongoing DMEs like formula, trach supplies, or G-tube supplies. And then we have a pick list for occupational, physical, speech therapy, specialized behavioral health for psychiatrists, behavior meds, counseling, mental health rehab, etc., dental services, eyeglasses, transportation, diapers, and then school. You can use that one for anything on the IEP that you need to document, like therapies, assistive technology, social worker, or nursing. And then we have a vocational employment. You'll use transition if the beneficiary will be 20 and a half years old, that plan of care year. Pediatric day healthcare, ABA, other home modifications, community services. We have redetermination if the SOA is going to expire that plan of care year. OCDD services for family flexible fund, family support, or respite. And then we have CSOC for wraparound and any of the other CSOC services that they may be requesting or receiving. Evaluation for psychologicals, CVEs, etc. EPSDT screening exam, hearing aids, hospice services, and then physician or professional for any needed referrals for doctors and anyone that they're overdue for a visit with. Okay, then you're going to select how the need was determined from the pick list, and then you're going to use the checkbox to indicate if the service is requested. If a service is not being requested now, you have 3 options to explain why. Carried over resolve. So you're going to use that one if it's no longer an identified service need. And if it's like on an annual plan and you select carried over resolved, after I approve it, it's going to fall off of the service needs list. So when you go to do quarterly, you won't have to keep documenting like that it continues to be declined. We'll just take it off of there. Okay, and then you have family does not want if the need for the service has been identified, but the individual declines the service. So if one of their physicians or their school or you, the support coordinator, recommends a service, there's a need for it, but the family declines it, you would use family does not want. And then we have other explain next page. If the need for the service has been identified, but it is placed on hold until a later time. The individual will request the service need in the future. So again, that's if it's on hold. So if they want a service now and they were placed on a wait list, that service is requested. Like they would prefer to be able to go to ABA after school now. So that's not appropriate. So only use the other explain next page if it's on hold for the future. And then that way we keep it on there as a service need. You can continue to ask the family about it during your quarterly visits and make sure that you restart PA tracking when the service is actually requested. And then always explain your reason in the additional information box on the next page. So that is also like a very common deficiency that like you have a service need on hold that earlier in the plan you said was requested, or you don't explain like why you selected one of those reasons. Okay, and then you're going to select the primary goal from the pick list, and you'll use the check boxes to indicate if the service is currently received. And then you're going to check the appropriate box of who will be providing or funding the service need, and your options are Medicaid, school, community, family if it's private insurance or the family's choosing to pay for it out of pocket, or OCDD. And then requires PA tracked by support coordinator must be checked for all requested Medicaid services that require a prior authorization unless both a valid reason for not tracking is selected and how the SC will ensure the service is received is documented in the additional information section. So in order to generate a PA tracking log or for them to even show up on your tracking required action, you have to have the Medicaid box checked and you have to have requires PA tracked by SC checked. And then you'll indicate the amount approved and assure and document at the time of the CPOC meeting that the individual understands that services and goals may be added whenever a request is made if they choose not to access a service when the need is first identified. So after the initial plan of care is approved, you can bring forward as many interim CPOCs as you need to make adjustments to any part of the plan to add any service needs. Okay, and then Medicaid and requires PA tracked must be checked in order to generate the required PA tracking log. And then we give y'all 6 options for any reasons, valid reasons for not tracking any Medicaid services. So the first one is going to be a PA is not needed to receive that Medicaid service. So if Gainwell or the MCO does not issue a prior authorization for that service need, then we can't do PA tracking because there's never going to be a PA. So reason 1 would be for that. If the PA is issued monthly, you can select reason 2, but you should also enter that monthly PA into your tracking log so that you have the documentation to support that. If the extended home health nurse is the person ordering and tracking the medical supplies, we don't have to do additional PA tracking for that. And then if the beneficiary has been placed on a wait list, but you must complete the waitlist placement steps as identified on page 62 of the handbook. And then number 5, the beneficiary is receiving the service without a PA. And there's a little bit of confusion about this one as well. So this is regarding the Appendix R4 exception. So it was that therapy providers have up to a year to bill for the services that they provide. So some of them wait a really long time to submit the PA request, but they're providing the therapy. So if they're with an MCO and that MCO does not require a PA for the therapy, you should be selecting reason 1, a PA is not required. You can use reason 5 if they're receiving the service without a PA. And then when the PA is obtained, up to a year later, we would get a copy of that PA and enter it into the system and restart tracking. And then reason 6, the beneficiary is in CSOC and the service is being authorized by Magellan. And you can refer to pages 60 to 63 of the handbook for more detailed information. And then this is what the service needs looks like on an ALSIS. So any questions about that stuff? Okay, and then section 4 is the additional information section. So CPOC participants, the beneficiary and the legal guardian must be present in order to hold a CPOC meeting. So you're going to have your paper form where everyone present is going to sign in the planning participants box. And then the beneficiary and or legal guardian or authorized representative will sign and date the completed CPOC. The support coordinator conducting the meeting will sign, and then the SC supervisor must sign indicating they completed their review prior to submitting an approvable CPOC to SRI. And then in ALSIS, when you're working on your plan of care electronically, you're going to, like everyone listed on your planning participants, you're going to document that in ALSIS, so those two should match. The signature date is going to be the date that they signed the paper form, not the date that you're entering it into the system. And then the support coordinator will sign and date the CPOC and have their supervisor review the plan. So to get your supervisor to review the plan, you'll check the box to submit for supervisory review. Okay, and then the additional information section is provided to address information regarding service needs and supports. The names of all service providers and any additional strategy information is to be placed in this section. So if you selected that you're not doing PA tracking because the beneficiary was placed on a wait list, you need to document all of the following. So document that you offered alternative providers that may not have a wait list and the response received. Document that the waitlist placement was confirmed with the provider. Document that you notified the PAL if it's a legacy Medicaid service or the MCO if it's a Medicaid managed care service, and document how you will ensure they move up the wait list. And you must follow up with the provider at least quarterly. So if you haven't done all of those things yet, then you should still have Medicaid and PA tracking checked. You should also open up a tracking log to document what provider they're on the wait list with. And then you're going to have your 15-day contact completed because you called the provider to confirm the waitlist placement. And then you can document in the notes box when you notified either the PAL or the MCO of the waitlist placement. And then we should see a service log in there at least quarterly of you following up on the waitlist placement with the provider. You can't follow up with the family. You need to call the provider at least quarterly to make sure that they're moving up the list. And then if you ever check family instead of Medicaid for services that are typically covered by Medicaid, explain why. So like if it's being covered by private insurance or if the family is choosing to purchase, etc. If any need is marked as carried over resolved, family does not want, or other explain next page, explain why. And then you'll document that you reviewed the Medicaid services chart, Medicaid EPSDT services, and information on EPSDT screening services. And you'll identify how often the goals and support strategies will be reviewed. The CPOC must be reviewed by the support coordinator at least quarterly and revised annually and as needed. And then, like if I tell you I'm looking for something in the additional information box, it's that box at the top right, additional information about service needs and supports. And then section 5 is the CPOC approval information where the SC supervisor will sign off documenting that they approve and agree with the content of the CPOC being submitted. The formal information documents listed under evaluation documentation used to develop the CPOC, the prior plan of care, service logs, and quarterly reviews must be reviewed by the supervisor for identified needs and the status of requested services. The entire CPOC must be reviewed to ensure that all identified needs are addressed and required information is included. Information is edited and updated and no discrepancies exist. And then they'll check the submit for review by LDH box when they're ready to submit it electronically. And then there is a See Service Tickets button, and this allows you to review all service logs from the prior CPOC year, which is required as part of the CPOC approval process. Yeah, and then okay, so the SC supervisor cannot be the person that completed the plan. So if I ever see that the SC and the SC supervisor is the same person, I would have to deny it and send it back. So if the SC supervisor is completing a plan for some reason, then they need to have another supervisor available to review that CPOC and submit it to me. Okay, and then I will review the CPOC to assure that all components of the plan have been identified. If any deficiencies exist, I will list them in the approval denial notes box and return the CPOC for resubmittal. So you can review the approval denial notes box on all returned CPOCs, and an approved CPOC may have a note to address something on an interim or information regarding the PA. Like if I ever issue a short-term PA, I'm going to document why and what the new plan of care dates are going to be. And then occasionally I'll want you to update something minor or maybe something in the demographics that shouldn't hold up the CPOC approval. So just make sure you're always checking that box. An approvable initial CPOC must be completed and sent to SRI within 35 calendar days of the date of referral to the support coordination agency. If the approvable CPOC is submitted timely, the PA will begin on the CPOC participant's signature date. If the CPOC is late, the PA will begin on the approvable CPOC submit date, and you can refer to the aging report and ELSIS that's going to tell you how many days that plan has been linked to y'all. The annual CPOC meeting should not be held more than 90 calendar days prior to the expiration of the current CPOC. The approvable annual CPOC must be completed and submitted to SRI within 35 calendar days of the CPOC expiration date. If the CPOC is submitted late, you will not meet the flat rate billing requirement of a timely CPOC, and you can refer to the CPOC updates report in ELSIS, which will give you the first CPOC meeting date and the date that the CPOC is due. Okay, and then documents to submit to SRI, which you can do via fax or you can email them to me. Appendix X1 is going to be used for initial CPOCs and anyone labeled special needs in ELSIS. And then Appendix X2 is only going to be for the CPOCs that are randomly selected for monitoring, which when the supervisor checks the box to submit it to me, they'll get a little message box and pop up and tell you if it's selected for monitoring. Annual CPOCs that are not special needs and are not selected for monitoring are to have the documents placed in the case record and submitted to SRI immediately upon request. The SC is responsible for requesting and coordinating all services identified in the CPOC immediately upon completion of the plan of care and prior to approval from SRI. Since approval of Medicaid state plan services is through the prior authorization unit, there is no reason for the support coordinator to await SRI approval of the CPOC before making referrals for necessary services. Again, the CPOC does not control the services. The CPOC approval process only controls payment to support coordination agencies. And that's what the CPOC approval information looks like in ELSIS. And then we have the typical weekly schedule, which is a paper form, and that's a tool that the SC uses to assure that services are delivered at appropriate days and times and do not overlap unless it's medically necessary. Include all approved services the beneficiary is currently receiving and any new services that they're requesting. Show when the beneficiary is in school, at home, or participating in other activities. The schedule can be forwarded to in-home providers and prospective providers to support and clarify prior authorization requests. If prior authorization is denied and not appealed, or if for any other reason the plan services are not delivered, the schedule should be amended to reflect services actually put in place. If the beneficiary wishes to change any of the times for established services, the support coordinator shall give the revised schedules to the appropriate providers, informing them of the time changes to facilitate the change, and the document can be kept in the case record. Okay, now we're going to talk about the coordination of services. So once a needed Medicaid service has been identified in the CPOC, it is the support coordinator's responsibility to coordinate the service. Again, do not wait for SRI to approve the CPOC. The support coordinator should provide as much assistance as possible to the family to identify and obtain other non-Medicaid services that are identified in the plan. The CPOC is considered a holistic plan. Therefore, the support coordinator is responsible for coordinating all identified service needs, including paid and unpaid supports, as well as non-Medicaid services. The support coordinator must be knowledgeable of potential community resources, including formal resources such as SNAP, SSI, and housing. Some Medicaid services, such as PCS, home health, and durable medical equipment, require prior authorization before they can be provided. And you can refer to the Medicaid Services Chart, Appendix C. Typically, a Medicaid enrolled provider of the service develops and submits an application for the service to the prior authorization unit. Requests may be denied if the item or service requested is not medically necessary or if it is outside the scope of services covered by Medicaid. A notice of denial would be sent to the beneficiary, the provider, and to you, the support coordinator. The beneficiary then has the right to appeal the denial. For beneficiaries in legacy Medicaid for their physical health services, prior authorization requests are acted on by the prior authorization unit of Gainwell Technologies, a company that contracts with the Louisiana Department of Health to perform this function. For beneficiaries in the Medicaid Managed Care Program for their physical health services and or behavioral health services, prior authorization is handled by the individual managed care organization. The beneficiary's MCO must prior authorize some specialized behavioral health services, including community psychiatric support and treatment, unless they are enrolled in the coordinated system of care. For children and youth enrolled in CSOC, their behavioral health services are authorized by Magellan. Okay, so again, legacy Medicaid is the traditional Medicaid for people who are not enrolled in an MCO for most of their health services. And then the Medicaid Managed Care Program is a managed care system for physical health, specialized basic behavioral health, and non-emergency medical transportation services. The 6 MCOs working statewide are Better Health, AmeriHealth Caritas, Healthy Blue, Humana Healthy Horizons, Louisiana Healthcare Connections, and United Healthcare Community Plan. Chisholm class members are part of the voluntary opt-in population for physical health services, meaning they may enroll in an MCO for their physical health services at any time. They may disenroll from an MCO for their physical health services anytime, effective the earliest possible month that the action can be administratively taken. And for more information on opting in and disenrolling from the Medicaid Managed Care Program for physical health services, you can refer to Medicaid Managed Care Appendix H or contact the Medicaid Managed Care Program hotline toll free at 1-855-229-6848. Okay, so all Medicaid beneficiaries will have an MCO for their specialized behavioral health services unless they are enrolled in the coordinated system of care waiver, in which case most of their specialized behavioral health services will be accessed through Magellan. And all Medicaid beneficiaries will have an MCO for their transportation services. Support coordinators are required to validate EPSDT beneficiaries' Medicaid eligibility through the electronic Medicaid eligibility verification system at the beginning of every month. The MEVs will provide the support coordinator with current information on the beneficiary's Medicaid coverage, including their MCO. SRI will populate the physical MCO agency and the behavioral MCO agency fields in ELSIS based on the data file SRI receives from Gainwell Technologies. If the physical MCO agency field is blank, the beneficiary has legacy Medicaid for their physical health services. And if the behavioral MCO agency field is blank, the beneficiary is enrolled in the coordinated system of care and is receiving their specialized behavioral health and CSOC services from the CSOC contractor Magellan Health Services of Louisiana. And if the physical MCO agency field and the behavioral MCO agency field is white, like meaning y'all can edit it, and that just means that that beneficiary was not on the file that we received from Gainwell. So y'all would be responsible for keeping those fields updated based on what you see on the Medicaid eligibility verification. And I have a handout that I've sent to y'all about how to read that. Like it'll say specialized behavioral health on the left, and then on the right, it'll give you which MCO they're with. And then if it doesn't have an MCO for physical, then they're with legacy Medicaid. So I'll get that sent out to y'all for anyone that doesn't have it. The support coordinator plays a role in the prior authorization process by assisting beneficiaries in identifying services they will request, providing the specific medical information forms the physician must complete for the requested services. And you can refer to Appendix R1 for a lot of the forms, or the LA Medicaid or LDH website. assisting with the scheduling of physician appointments, transportation, etc., to have the forms required for a PA request completed, locating providers willing to submit the request, assisting if necessary, and assembling documentation needed to support the PA request, making sure providers submit requests timely and tracking the status of the request, communicating with the prior authorization liaison, notifying them of any upcoming doctor's appointment, and helping to supply any missing documentation of medical need. Follow through with the request for services until the PA is either approved or denied based on medical necessity, and assisting the beneficiary with making a decision about whether to appeal any denials of services, and assisting with the appeal if the beneficiary decides to appeal and wants assistance. So those two slides kind of cover everything that's part of the PA tracking process, and then we're going to talk about each one individually. So the first step would be to locate a provider. So for physical health services, they're either going to be accessed through legacy Medicaid or through the beneficiary's MCO. So if you need to find a legacy Medicaid provider for physical health services, you can call the specialty care resource line to find medical providers of various types and specialties for their beneficiaries, and to help identify needed resources or needed sources for referrals that may otherwise be difficult to find. The specialty care resource line is supported by an automated resource directory of all Medicaid enrolled providers of medical services, including physicians, dentists, mental health clinics, and many other healthcare professionals. The database is updated regularly. You can also get a list of available legacy Medicaid providers through the medicaid.la.gov website. You would click locate a provider and then select the service need that you're looking for under provider groups and provider specialties. And then you can search by region or parish where the beneficiary lives. And to search for EPSDT PCS providers, that is listed as a provider specialty under the personal care services provider group. And you can also find the direct website to find a provider there. Okay, to locate Medicaid managed care providers for physical health services. So support coordinators should assist with locating a provider contracted with their MCO. Resources for locating providers include the online provider directory at myplan.healthy.la.gov. You would select choose and then find a medical or dental provider. And then you can search by medical providers for any physical health services. And you can search by zip code, city, or parish. And then you can search for specific providers to see which plans they are contracted with, or you can search for providers by specialty like PCS, neurology, etc. And to search for PCS, you can select personal care attendant from the provider specialty field. Your other option is to call the member services line at each MCO to locate a provider in their network, or you can access the MCO's website to identify contracted providers. Okay, and then behavioral health services is either going to be accessed through the beneficiary's MCO or through Magellan if they're in CSOC. So this is the same thing that we just covered, locating behavioral health providers and Medicaid managed care. Only instead of searching for medical, you're going to search for behavioral health providers. And again, you can call the member services line or go to the MCO's website. And then to locate behavioral health providers' evidence-based programs, you can use the interactive map found at laevidencetopractice.com or contact the beneficiary's MCO and ask for help from a behavioral health care manager to find an in-network evidence-based program provider. And then for youth enrolled in CSOC, you can call the CSOC contractor Magellan at the 1-800 number, or you can discuss it with the beneficiary's wraparound facilitator. And then transportation services, the transportation phone numbers for each MCO can be found on Medicaid Managed Care Appendix B. And then dental services, which that's also going to be on the Medicaid eligibility verification system. They will either be with DentaQuest or MCNA Dental, so you can call them or visit their websites. Okay, and then waitlist placement. If at any time a beneficiary is placed on a waitlist for a needed service, the SC must document that the class member was offered alternative providers for whom there might not be a waiting list and the response received. For legacy Medicaid services, the SC must notify the LDH PAL of waitlist placement using Appendix S. And for Medicaid managed care services, the SC must notify the Medicaid managed care case manager using Medicaid managed care Appendix Q. The SC must follow up on waitlist placement with the provider at least quarterly to ensure they move up the waitlist. What if you are unable to locate a legacy Medicaid provider? If you're unable to locate a legacy Medicaid provider for a Chisholm class member, call the contact person listed on the Medicaid services chart for assistance. Make sure you contact the correct program subject matter expert when information is needed, like DME staff for DME related services, etc. If the service contact person is unable to assist, call the LDH program staff line at 1-888-758-2220 and tell them you cannot find a provider. The LDH program staff's line's hours of operation are 8 a.m. to 4:30 p.m. with a voicemail message system for overflow and after hours calls. The support coordinator must fax the referral to LDH PAL form, Appendix S. If a provider cannot be located, LDH must take all reasonable and necessary steps to find a willing and able provider within 10 days. What if you are unable to locate a Medicaid managed care program provider? If you can't find a provider from the MCO's website or the provider directory, which is willing to submit a prior authorization request, call the MCO's member services line, which operates from 7 a.m. to 7 p.m. Monday through Friday for assistance. The support coordinator must fax the referral to Medicaid managed care case management form within 3 days of the date of service request to get assistance from the MCO with locating a provider. If the MCO is unable to locate a willing provider within 10 days of the referral, the SC should submit a referral to the LDH PAL using Medicaid Managed Care Appendix S. LDH will forward the referral to the MCO, requesting notification upon resolution. What if a legacy Medicaid provider is unable to find staff? If the provider is unable to find staff after the service has been approved, the support coordinator must notify the LDH PAL using the referral to LDH PAL form Appendix S. The support coordinator must call the LDH program staff line. The support coordinator should assist the family in finding another provider agency with available staff from the LDH website list of providers. If a provider cannot be located, LDH must take all reasonable and necessary steps to find a willing and able provider within 10 days. What if a Medicaid managed care provider is unable to find staff? If the provider is unable to find staff after services have been approved, you'll call the MCO's member services line, which operates from 7 a.m. to 7 p.m. Monday through Friday for assistance. Support coordinators should fax the referral to Medicaid managed care case management form to the MCO to request assistance. And if the MCO is unable to resolve the issue within 10 days of the referral, the SC should submit a referral to the LDH PAL using Medicaid managed care Appendix S, and LDH will forward the referral to the MCO requesting notification upon resolution. Okay, PA tracking begins with the request for the service, not when the choice of provider or prescription is received or when the CPOC is approved. To begin PA tracking, add the service as a service need on the CPOC service needs and support section in LSIS and check the Medicaid and requires PA tracked by SC boxes for that service strategy. Then you'll follow the prompts on the tracking required action report, beginning with opening an EPSDT prior authorization tracking log. The electronic EPSDT PA tracking log will be used to document the nature and specific amount of each service being sought, provider and PAL referrals, provider contacts, and information about approval, denial, and appeals. A separate tracking log is completed for each service that requires prior authorization. And then you'll bring forward a new renewal tracking log for each PA cycle after the reminder notice for renewals is sent to the provider or the MCO. The date the reminder notice is sent is the date of referral for a new tracking log. And then always keep the date of service request the same as the previous tracking log. If you update that date, you'll still be getting prompts on the old log. And then a new change in service tracking log is used for changes in existing services. So if they need to change providers, they want to request additional hours. And then again, keep the date of service request the same as the previous tracking log. The PA tracking log is an important tool for support coordinators for several reasons. It will help you assure the beneficiary is receiving the services requested. It will serve as a reminder to contact the provider if you have not received a copy of the PA. It will serve as a reminder to make required PAL referrals, allow you to know at a glance when and if services were or were not approved, serve as a reminder of when the notice should be sent to the provider to renew services, allow you to document information about the PA decision notice, and allow you to document that you offered or provided appeal assistance to the beneficiary and provided the appeal brochure. The PA tracking log provides space for ongoing tracking information relating to the status of the prior authorization service, including the type of service requested, which again, you have to have it as a service need and have Medicaid and PA tracking checked in order to be able to select it from that pick list. And then you'll document the date of service requested, the date of choice of provider, who the provider is, your required referrals and provider contacts, the date of decision of the PA notice, the amount approved, PA approval and dates, and any appeal information. Okay, so when a service is requested, the support coordinator should give the individual a choice of providers unless they are already satisfied with a provider. Assist the individual in contacting prospective providers and finding out if they are willing to submit prior authorization requests. Have the individual list the provider they choose and sign the choice of provider form for EPSDT Medicaid providers, which is Appendix Z. Give the individual the medical information forms that are required for that specific service. And again, many of the forms can be found in Appendix R1. Assist with scheduling the doctor appointment, transportation, etc. as needed, and assist the individual and provider in gathering the appropriate documentation needed to support the request. Once the beneficiary, and then this is tracking required actions for legacy Medicaid. So once the beneficiary has chosen a provider, the support coordinator will complete the referral to provider, Appendix Q form, and submit it to the provider within 3 calendar days of the date of choice of provider. For initial CPOCs, the referral to provider must be made within 3 calendar days of CPOC completion or within 3 calendar days of the choice of provider if the date of provider selection is later than your plan of care meeting. Within 15 calendar days of the referral to provider, you'll contact the provider to confirm that they are working on the request and to see if they need any assistance gathering information. Within 35 calendar days of the referral, you'll contact the provider and ask if the request has been submitted to Medicaid or if there were problems that you could assist with. And again, those are within 15 days and within 35 days. So you don't have to wait till the 15th day. You can do it the day that you send the referral. And then your second contact just needs to be made within 35 days. And then those are the only 2 that we're going to document on your tracking log, but you would obviously continue to follow up with the provider and document those contacts just on a regular service log. If a notice of decision has not been received 10 calendar days after the date the provider said they submitted the request, you'll contact them to follow up, or if you get a call from the PAL. And then 45 to 60 calendar days prior to the date the services are scheduled to expire, you should remind the provider to renew the prior authorization request. The provider must submit the renewal request at least 25 calendar days prior to expiration to assure uninterrupted services. And then all that's covered on Appendix T2, which has our flow sheet. And then the dates are going to be tracked for you on the tracking required action report. Okay, and then our prior authorization liaison referrals. If a prior authorization packet has not been submitted within 35 calendar days, you'll complete the referral to LDH PAL form, Appendix S, and submit it to the LDH PAL. Also inform the beneficiary about their right to change providers. If a prior authorization decision has not been received within 60 calendar days, you'll complete a referral to the LDH PAL. And also inform the beneficiary about their right to change providers. So again, those are the two that are going to show up on your tracking log. And there's other reasons why you would submit a referral to the PAL, including to alert them that a renewal approval has not been received and the previous PA expired, to alert the PAL that a provider cannot be located to submit a request for prior authorization, to alert the PAL that the provider has placed the beneficiary on a wait list, or to alert them that a provider is not providing services at the times the beneficiary requested and or the amount of services prior authorized and the problem cannot be resolved. So this is what the tracking logs look like for legacy Medicaid. Do you have any questions about what information goes in those boxes? And then the pink boxes are going to be populated based off of your service log. So if you ever did a provider contact or a PAL referral and it's not showing up in the pink box, you can give me a call and we can look at the coding for it. You do have to tag it as either a 15-day or a 35-day contact or a 35-day or 60-day PAL. And then you have to tell it what service need you're doing it for. Okay, and then tracking required actions for Medicaid managed care. So once the beneficiary requests a service, the support coordinator must complete the referral to Medicaid managed care case management form and submit it to the Medicaid managed care case manager. Fax numbers can be found on Medicaid managed care Appendix A. And then referral to Medicaid managed care case management should be made within 3 calendar days of CPOC completion, or within 3 calendar days of the date of service request if the date of service is later than the plan of care meeting. And then you're going to do a second referral within 3 calendar days of the date of choice of provider if the provider was not known upon the request for service. And then this just kind of explains that again. So your first referral to MCO will be to let the MCO know this service is requested. Your second referral will be to let the MCO know the choice of provider. And then you would only see one referral box on your tracking log if it's a renewal or if the date of service request and the choice of provider date are the same, meaning they like requested PCS and knew what provider they wanted on the same day. So you would only do one referral for that. And again, you will not see the second referral teal boxes on your Medicaid managed care tracking log in that case. Okay, so required provider Medicaid managed care case management contacts. If it's an initial request and the choice of provider is not known, you're going to send that first referral to let them know the service is requested. And then you're going to do a 15-day and a 35-day contact with the MCO to check on the status of the referral and seek assistance with the choice of provider, alerting the MCO of any issues that you're finding with finding a willing provider. And then once a choice of provider has been made, you're going to send your second referral, and then you can complete your 15-day or your 35-day contact with the provider or the MCO. If a PA packet has not been submitted to the MCO, seek assistance from the MCO and continue to follow up with the provider and Medicaid managed care case manager until the packet is submitted. And then for renewals, or if they knew what provider they wanted when they selected the service, you would do that one referral to the MCO, and then your 15-day and 35-day contacts could be with the provider or the MCO. And again, if the PA packet is not submitted, seek assistance from the MCO and continue to follow up with the provider and Medicaid managed care case manager until the packet is submitted. Contact should be made if a notice of decision has not been received 10 calendar days after the date the provider submitted the request or a call from the PAL has been received. And then renewals are going to be 20 to 60 calendar days prior to the date the services are scheduled to expire. You should remind the Medicaid managed care case manager to renew the prior authorization request. And then required LDH PAL referrals, if after 60 calendar days from the choice of provider date, the support coordinator has not received a decision and the MCO has been unable to resolve the issue, the SC must complete the referral to LDH PAL Medicaid managed care member, which is Medicaid managed care Appendix S. And then other reasons why you would send a Medicaid managed care case manager referral would be to alert the MCO that you've been unable to locate a willing provider, to alert the MCO that a renewal approval has not been received and the previous PA expired, to alert the MCO that a provider is not providing services at the time the beneficiary requested and or the amount of services prior authorized and the problem cannot be resolved, or to alert the MCO that the member was placed on a wait list. And then other reasons why you would send a referral to LDH PAL for Medicaid managed care members would be if you tried to resolve the issue with the MCO and the MCO has been unable to resolve the issue within 10 days of the referral. So to alert the PAL that you've been unable to locate a willing provider, the renewal approval has not been received and the previous PA expired, or the provider is not providing services at the time requested or the amount PA'd. Prior to sending the referral to LDH PAL Medicaid managed care member, the support coordinator should document all contacts and all attempts to contact the MCO PAL and Medicaid managed care case manager. The support coordinator must attach the completed referrals to Medicaid managed care case management, along with all logs and emails related to resolving the issue with the MCO PAL. If the PA notice is not received from the provider, the MCO can give you the PA information over the phone, but do not take verbal PA information from providers. And then this is what the Medicaid managed care program tracking logs are going to look like. And again, you won't see that first row of teal boxes if it's a renewal or if your date of service request is the same as the date of choice of provider. And then the teal boxes at the bottom are going to show up for you to track any MCO appeals. Okay, renewals of prior authorization for legacy Medicaid services. The provider must submit the PA packet no less than 25 days prior to expiration of the PA for services to continue without interruption. Some services may not require a full prior authorization packet. For legacy Medicaid services, the support coordinator must send a reminder letter, which is just the referral to provider Appendix Q form, to the provider no less than 45 and no more than 60 calendar days prior to the expiration of the prior authorization. And then renewals of PAs for Medicaid managed care services. The number of days prior to expiration that the provider must submit the packet for prior authorization for services to continue without interruption varies from plan to plan, and you can see Medicaid managed care Appendix D. Some services may not require a full prior authorization packet. For Medicaid managed care services, the SC must send a reminder letter, referral to Medicaid managed care case management, to the MCO no less than 20 days and no more than 60 calendar days prior to expiration of the PA. The LSIS service log should be used to provide a narrative of activities related to the request for EPSDT services, including each activity and contact with the provider, the beneficiary, and the PAL. A separate service log should be used to document activity related to a specific prior authorized service. The LSIS service log should be used for documenting all contacts with the beneficiary, provider, MCO, SRI, LDH program staff line, and the PAL. The service log should also be used to document the receipt or the approval, denial, or reduction of services, the monthly contact with the beneficiary or family regarding the status, of implementation of services, and all support coordination activities. These entries must be up to date, as SRI and/or health standards may request to review this information in order to verify services and prior authorization information. So this is what the service log looks like. And then just make sure that y'all are clearly documenting how the contact was completed, who it was completed with, and what the result of the contact was. So I shouldn't be seeing any service logs that say like SC completed 15-day contact. That doesn't tell me who you talked to. It doesn't tell me what's going on with the PA request, what forms are needed, what the result of the call was. Like, I should be able to read all your logs and figure out what's going on with the service. Okay, and then the prior authorization liaison, the PAL unit was established to facilitate the PA approval process for Medicaid beneficiaries under the age of 21 who are on the Developmental Disabilities Request for Services Registry. The Chisholm versus LDH lawsuit settlement stipulates that the support coordinator is notified of request, status, and any delay in the PA approval process. The PAL will maintain a tracking system to ensure support coordinators remain aware of the status of PA request, submission, decision dates, and reconsiderations. The PAL will assist with problems on each prior authorization request so that a decision is rendered as to medical necessity. PA requests are given to the PAL when the request cannot be approved due to lack of documentation or technical errors like overlapping dates of service, incorrect procedure codes, or the prescription not being signed by the doctor. The PAL will attempt to resolve the problem. Within 24 hours of the PAL receiving the request, the PAL makes the initial contact by phone or fax with the provider, the beneficiary, and the support coordinator. If the issue is not resolved after 10 days of initial contact with the provider, a notice of insufficient documentation is sent to the provider, the beneficiary, and the support coordinator, advising them of the specific documentation needed. The beneficiary has 30 calendar days to either supply the needed documentation or notify the PAL with the appointment date that has been made with the health professional to obtain it. So your role is to communicate promptly with the PAL to facilitate requests for information, communicate with the individual and the provider, and provide assistance in assembling documentary support on PA requests, and follow up so that a PA decision is received instead of having the service denied due to a lack of information. Advise the PAL of providers not actively developing requests, inform beneficiaries of their right to choose another provider, and assist beneficiaries in locating other providers. If a notice of insufficient documentation is received, assist the beneficiary in obtaining the required documentation. If you are not sure enough additional information is available, help the beneficiary schedule an appointment with a health professional and return the second page of the notice filled in with the date of the appointment to the PAL. When a SC closes a PA tracking log that had a PAL referral, the SC should notify LDH of the closure date and reason. This allows LDH staff to focus on the active PAL referrals. And then we've got contact information for the Gainwell Technologies PAL, and then our single point of contact for the LDH PAL is Nancy Spillman. And you only need to contact the Gainwell Technologies PAL to return calls. And then for the prior authorization liaisons at the MCOs, you can refer to Medicaid Managed Care Appendix A. And then we've got sample Medicaid prior authorization packets and samples of the PAL notices and Appendix R and R3. So to summarize the PAL and support coordinator's roles, if additional information is needed to process the request, the PAL will contact the provider, beneficiary, and support coordinator within 24 hours. The support coordinator is to assist in obtaining the additional information, but this does not supplant the responsibilities of the provider. The support coordinator will receive a copy of all notices, approved, denied, reduction in services, and requests for additional information regarding the requested service. If a beneficiary service is denied or partially denied, the E EPSDT PA tracking log and ELSIS service log should document the following. So you'll document that the beneficiary was informed of the appeal rights. They were given a copy of the appeal brochure. The support coordinator offered to assist with the appeal. If assistance was given, the coordination of documents, the submission of documents to the appeals office, or if no documentation was available, the date the appeal was filed, and if the support coordinator did not assist with the appeal, the reason assistance was not provided, and if an appeal was filed, the response to the appeal and the final decision. For services authorized by the Medicaid Managed Care Program that are denied or partially denied, the beneficiary provider and the SC will receive a notice of denial. If services are denied or partially denied, the beneficiary may appeal the decision by following the appeals procedures sent to them, the provider, and the support coordinator by the MCO following the denial or partial denial. The support coordinator must inform the beneficiary of his or her appeal rights, go over the appeals brochure that both parties received from the MCO, and offer to assist the beneficiary with the appeal process fair hearing if they decide they want to request an appeal. If the internal MCO appeal decision is upheld, the beneficiary has the right to appeal to the Department of Administrative Law, and you can refer to Medicaid Managed Care Appendix F and T1. For beneficiaries of legacy Medicaid or for those with Medicaid Managed Care Program after the internal appeal process has been exhausted, if services are denied or partially denied, or any individual whose claim if services are denied or partially denied, or for any individual whose claim for medical assistance under the plan is not acted upon with reasonable promptness, or if the member alleges that services are not made available with reasonable promptness, the beneficiary may appeal by mailing or faxing a written request for a fair hearing to the Division of Administrative Law, or by filling out the form at the website. The support coordinator must inform the beneficiary of his or her appeal rights and provide the appeals brochure. Review the brochure in its entirety, and information on appeals can be found on the internet at the LDH website. Explain the beneficiary can receive the services or items that have been approved and appeal for whatever was denied. They do not need to choose between filing an appeal and receiving the approved services. Explain that services will be continued pending appeal if the appeal is filed within the 30-day appeal period. The timeline for continued services will revert back to 10 days in March of 2025. The support coordinator must ask the individual if they need or want assistance with filing the appeal, and the SC must assist with an appeal if assistance is wanted by the beneficiary. Regardless of whether or not the support coordinator is assisting, they must follow up with the beneficiary within 20 calendar days of the appeal request to see if they have received a response or need additional assistance. The support coordinator should follow up again with the beneficiary at least 90 calendar days after the appeal was sent to check on the final decision regarding the appeal. And you can review the appeals section of the handbook, page 92. Okay, other requirements. The support coordinator must make contact with the beneficiary as needed until each service included on the CPOC is fully implemented, including receipt of all prior authorized services. Contacts may be required to assure implementation of requested services, determine a service start date after the PA is received, assist as requested with identified needs and problems with providers, follow up on obtaining information to complete a PA request, or to offer assistance with appeal. So again, you don't want to wait until your next monthly contact. If something comes up or they're requesting a service and you're working on it, you would want to follow up as needed. The support coordinator must make contact at least monthly to assure implementation of the services requested on the CPOC. If the beneficiary is not satisfied with their provider, the support coordinator shall follow up with the provider. And if the issue cannot be resolved, you'll alert the PAL for legacy Medicaid services, or alert the MCO for Medicaid managed care services. If the MCO cannot resolve the issue within 10 days of the referral, alert the LDH PAL using Medicaid managed care Appendix S. The support coordinator must complete a face-to-face visit with the beneficiary and parent or legal guardian each quarter in order to identify service needs and status through review of the CPOC. The service needs section of the quarterly review should document if services are received and if the beneficiary or family is satisfied with their services and their providers. You'll also document any additional services requested, any scheduling issues, and you'll complete the CPOC quarterly review checklist and progress summary located in LSIS. The face-to-face quarterly visit does not have to be completed in the beneficiary's home. However, the CPOC meeting, initial or annual, must be held at the beneficiary's home, and the original signature pages must be kept in the case record. If any complaints against support coordinators or legacy Medicaid providers are detected as a result of the quarterly review, the beneficiary should be given the participant complaint form, which is Appendix M, to complete and return to health standards. If the support coordinator detects the beneficiary has any dissatisfaction with the service provider, it is the SC's responsibility to assist in resolving any problem and let the beneficiary know of his or her right to change providers. If the beneficiary has a complaint against their MCO, they should be given Medicaid Managed Care Complaints Form, which is Medicaid Managed Care Appendix I, and that includes the Medicaid Managed Care Program Assistance Line and the healthy@la.gov email address for filing complaints against a Medicaid Managed Care Program provider or an MCO. And then this is what the LSIS CPOC quarterly review looks like, and I'll have some updates on that at the end. All right, changes to the CPOC including the typical weekly schedule should be made to reflect changes if prior approval of a requested service is denied and not successfully challenged through a fair hearing request or other advocacy. When strategies are needed to deal with problems with services or providers, resolving problems and overcoming barriers to beneficiaries receiving services is a key goal of the CPOC process. Changes should be made when significant new information is obtained from a medical appointment or assessment, including a psychological and behavior services assessment. The CPOs should be updated, and goals and objectives should be added and or revised according to the most recent information available. The EPSDT quarterly report will be completed using information entered into LSIS. Each agency must have all the required information entered at the end of each quarter so that the report can be generated. It's the responsibility of the agency to identify beneficiaries with a PA not issued within 60 calendar days of their request. As part of that identification, the agency must review all documentation, including the CPOCs, PA tracking logs, service logs, etc., prior to the end of each quarter. The quarterly report is due to me by the 5th day of the month following the end of the quarter. So it's always going to be April 5th, July 5th, October 5th, and January 5th. The support coordination agency must use the quarterly report checklist, Appendix W1, and the report must include a printout of the quarterly report from LSIS, which needs to be reviewed and signed, a quarterly report of CPOC revisions, which is Appendix W2 with a printout of the service needs changes report, any record reviews that are required for each PA not issued within 60 days, and each gap in prior authorization period, explanation of beneficiaries without a choice of provider. So you could submit a service log or just like a Word document of the status of each service need that doesn't have a choice of provider, and then documentation of EPSDT training for any new hires that quarter. The report will include the name of beneficiaries and the services for the following: beneficiaries with PA not issued within 60 days, beneficiaries with service gaps in authorization period, and beneficiaries who submitted requests for appeals within the quarter. The record review for the quarterly report is to be completed for each beneficiary and each service listed on the LSIS quarterly report as not having a PA issued within 60 calendar days or a gap in authorization period. And if you find that there is no gap, you could just remove that from the quarterly report. So like on your actual printout of the quarterly report where it has number of gaps, like just reduce it by 1 for each one that doesn't exist. And then you would fill out page 1 of the record review to document like when the previous PA expired and when the new one started to show that there's no gap or the gap was due to the family choice. The EPSDT specialist, if they are not the support coordinator over that case, is to complete the record review. If the support coordinator involved in the case is the EPSDT specialist, the on-site program manager, or their supervisor are to complete the record review. Either the number of trackings without a choice of provider must be 0, or documentation and explanation must be attached for each beneficiary and service without a choice of provider. SRI and the LDH attorney will review the information to assure that the beneficiaries are receiving the services they need and the assistance they need to access the services. SRI will request supporting documentation and information from the support coordination agencies as needed. Okay, and then training requirements. New SCs and trainees must receive EPSDT training during orientation and prior to being assigned an EPSDT caseload. All SCs and trainees must complete EPSDT training each year as part of their 20 hours of annual training. The agency's designated trainer and supervisors will be responsible for training the staff. And then all trainers and supervisors also must receive EPSDT training during orientation and prior to beginning supervision of any EPSDT support coordinators. And they'll also complete EPSDT training each year as part of their 20 hours of annual training. The agency must submit documentation of the training to me using the training log, which is Appendix W4. So following this training, I'll request that. And then anytime that you have new staff, you'll submit it with your quarterly report. The on-site program manager is responsible for assuring compliance with all program requirements, and the EPSDT specialist is to monitor that all EPSDT requirements are met. They both shall check the LSIS reports at least semi-weekly, and all deficiencies are to be addressed and resolved. And you can refer to handbook page 121 through 125 for more information on the LSIS reports. So common problems with the quarterly report, probably most common is not having all the documents. So you can use Appendix W1, which will clearly list everything that should be submitted. If there's going to be a separate list that's going to tell you services without choice of provider. So I should be able to see what the status is. I just want to make sure that it's not that there aren't any, that we're not having problems locating the provider. So it needs to be documented that like the family just hasn't made that choice yet. So document any barriers that you're having and strategies that you're using to find a provider. Let me know if you've contacted the MCO or the PAL. For the record reviews, there should be a separate record review for each one. Like sometimes y'all will try to put, you know, like if it was client A and they were on there for speech therapy and PCS, I would need 2 separate record reviews for that because those are 2 separate service needs. It's common for y'all to use older forms, and I did update it to a Word document this year, I believe. So Appendix W3 isn't like in an Excel sheet anymore. So hopefully it's a little bit easier for y'all to type in. But if you have any suggested edits to that form, let me know. And then I also like for y'all to put the reason that the PA was not issued within 60 days. That's clearly documented. I mean, I'm going to review y'all's service logs as well, but I have to put that on my report. So just if you can clearly let me know like what happened with it. I think that's everything. Oh, and then the number of service needs being tracked has to match the number of trackable services. So there's like a little spot at the bottom of the quarterly report where those numbers have to match. If they don't match, it will clearly tell you what service needs need to be tracked. So it's usually that a renewal was due, but the tracking log hasn't been opened for that. So that's another common one. Any other questions about the quarterly report or how to do the record review? So you're basically just like the supervisor or the specialist is reviewing the tracking log and the service logs to make sure that the support coordinator followed all of their timelines. So it'll tell you, like, did they offer freedom of choice? Were the 15-day and 35-day contacts completed timely? So I think I put them all in bold or like shaded the ones where if you answered no, then I should receive a corrective action plan to address that deficiency. So when y'all are like looking at the record review, just let me know if you have any questions about that. Okay, so reminders, the purpose of support coordination is to coordinate all services and to ensure the beneficiary receives the services that he or she needs. If at any time a provider is not actively working on behalf of the beneficiary, contact the PAL and contact SRI if you have questions, or your Bureau of Health Service Finances state office regarding policy. Okay, so now we're almost done. We're just going to go over Medicaid Managed Care Program and then our post-public health emergency section. Okay, so the purpose of this section is for y'all to use in conjunction with the handbook and the Medicaid Managed Care Program appendices. The managed care system for physical health and specialized behavioral health systems is called the Medicaid Managed Care Program. And then the 6 MCOs working statewide, again, are Aetna, AmeriHealth, Healthy Blue, Humana, Louisiana Healthcare Connections, and United Healthcare Community Plan. Most Healthy Louisiana members will receive all of their Medicaid covered services through their health plan. Chisholm class members may choose to have all of their health care through the health plan or only their specialized behavioral health services. This is called opt-in. So that just means, again, that they can enroll in an MCO for physical health and they can disenroll from an MCO for their physical health and go back to regular legacy Medicaid at any time, effective the earliest possible month that the action can be administratively taken. Some Medicaid beneficiaries only receive specialized behavioral health and transportation through their health plan. And then CSOC beneficiaries will receive coverage for all covered services except their specialized behavioral health and CSOC services, which will be received from the CSOC contractor, Magellan Health Services of Louisiana. Plan change effective dates are always on the first day of the month. Any transfer request processed on or before the second to last business day of the month will be effective the first of the following month. And any transfer request processed on the last business day of the month will be effective on the second following month from the date of the request. And I'll give you all examples. Chisholm class members who have previously disenrolled from an MCO may re-enroll in an MCO only during the annual open enrollment period, effective the earliest possible month that the action can be administratively taken. So open enrollment members do not need a reason to change health or dental plans. And that's going on right now between October 15th and 6:00 p.m. on November 30th. Chisholm class members have a 90-day disenrollment period from the effective date of the enrollment during which they can change MCOs for any reason. So that would be like going from one MCO to another. After 90 days, Chisholm class members will be locked into that MCO until the next annual open enrollment period, unless they opt out of the Medicaid Managed Care Program, meaning they go back to legacy Medicaid for their physical health, or they show cause for disenrollment from that MCO. Okay, so if you call the Healthy Louisiana line on April 8th, the effective date would be May 1st. If you call on April 29th, the effective date would be May 1st. but if you wait till the very last business day of the month, April 30th, then the effective date would not be until June 1st. For more information on opting in and disenrolling from the Medicaid Managed Care Program, you can refer to Medicaid Managed Care Appendix H, or you can call the Healthy Louisiana line. Chisholm class members can change their health plan in one of these 5 ways. You can go online, myplan.healthy.la.gov. There's a Healthy Louisiana mobile app. You can call the Healthy Louisiana line, or if they got the enrollment form in the mail, they can fax it or mail it back. Services excluded from the Medicaid Managed Care Program include dental services, with the exception of varnish, provided in a primary care setting, surgical dental services and emergency dental services, ICFDD, nursing facility, IEP, waiver services, targeted case management, services provided through early steps, and then personal care services for those aged 21 and over. MCO members may obtain excluded services under the Louisiana State Plan. However, Gainwell will pay for these, not the MCO. The MCOs are responsible for informing members how to access excluded services and assisting in the coordination of these services. The SC should reach out to the Medicaid Managed Care Case Management for assistance with obtaining excluded services. MCOs offer value-added benefits to their members, which are currently non-covered services by the Louisiana Medicaid State Plan. A complete listing of each MCO's value-added benefits can be found on the MCO comparison chart, which is Medicaid Managed Care Appendix G. And some examples would be GED test preparation, cell phone and service, or gym memberships. Okay, and then y'all's role. Support coordinators should assist Chisholm class members with selecting an MCO by providing information on all 6 plans using the MCO comparison chart. Support coordinators should ensure that Chisholm class members' providers are in network. Each plan has primary care physicians and specialists in their provider network, and you can search for providers by plan at myplan.healthy.la.gov. Support coordinators should ensure that the medications that they are currently prescribed are covered by the MCO's formulary. A common preferred drug list can be found at the website. It's important to check any medications not listed on the common preferred drug list with each of the plans to see if it's covered. Each plan covers different drugs and has different prior authorization and step therapy procedures. And you can refer to handbook page 8 for links to each MCO's pharmacy benefits page. So questions for Chisholm class members to answer before selecting a health plan: is their primary care physician in the health plan's provider network, or specialists they see in the health plan's network, are specialists and behavioral health providers they see in the health plan's network, and what special services does that health plan offer? Chisholm class members can call the Healthy Louisiana line to enroll or go online at myplan.healthy.la.gov. Support coordinators are responsible for informing the Chisholm class member of the MCO's contractual obligation to ensure transition of care when enrolling in or switching MCOs. MCOs do not require service authorization for the continuation of medically necessary covered services of a new member transitioning into the MCO, regardless of whether such services are provided by an in-network or out-of-network provider. However, the MCO may require prior authorization of services beyond 30 calendar days. The MCO will honor any active prior authorization up to 30 calendar days or until the transition of care is complete, whether or not the authorization is with an in-network or out-of-network provider. What should a Chisholm class member expect after enrolling in the Medicaid Managed Care Program? Within 10 days of a member enrolling, the MCO will send the member a welcome packet, including their member handbook and/or welcome letter. The MCO will also send the member ID card, and within 14 days of sending the packet, the MCO will call new members. And you can familiarize yourself with the member handbooks, and they're all found on those links. And then the member services numbers, which is also on Medicaid Managed Care Appendix D. Okay, so to access services, support coordinators should utilize Medicaid Managed Care Appendix A and B to contact the MCO to determine how the Chisholm class member can access specific services. This process may vary for each MCO. Support coordinators are responsible for assisting the Chisholm class member with obtaining the documentation, including prescriptions, for requesting prior authorization of medically necessary services. Support coordinators should also coordinate assistance with Medicaid Managed Care case management, the MCO PALs, and the LDH PAL via phone, email, fax, or referral form. If you need assistance locating a provider, again, you can go to myplan.healthy.la.gov, call the member services line, or go to the MCO's website. If you cannot find a provider from the Medicaid Managed Care Program website or the provider directory, which is willing to submit a PA request, call the MCO's member services line for assistance. You would also fax the referral to Medicaid Managed Care Management referral within 3 days of the date of service request to get assistance from the MCO with locating a provider. And if the MCO is unable to locate a willing provider within 10 days of the referral, the SC should submit a referral to the LDH PAL to alert them of the issue, and LDH will forward the referral to the MCO, requesting notification upon resolution. Support coordinators are responsible for assisting Chisholm class members with switching service providers. SC should send a referral to the MCO to inform them of the member's desire to change providers. Members have the right to change providers at any time. However, approved authorizations are not transferred between agencies. If a member elects to change providers within an authorization period, the current agency must notify the MCO of the member's discharge, and the new agency must obtain their own authorization through the usual authorization process. If a member is being involuntarily discharged, they should receive a written notice and appeal rights from the provider. SC should contact the MCO PAL if the provider fails to provide a discharge notice. Support coordinators should maintain communication with the Medicaid Managed Care case management through submission of the PA and the final determination. If the service authorization is denied, the support coordinator should assist the Chisholm class member with obtaining the required documentation and ensuring that the documents are submitted to the MCO. Support coordinators should assist the Chisholm class member throughout the appeal process if they choose to appeal, and you can refer to the Medicaid Managed Care Appendices T1, T2, and T3 for timelines. And then I've got a list here of all the reasons for referrals to Medicaid Managed Care case management. So to make a referral for a needed service, if a change in schedule is requested, if a renewal is needed, if they want to choose a new provider or they've selected a new provider, if a PA has expired, if a provider cannot be located to submit a request for prior authorization, if a provider is not providing services at the times the member requested or the amount of service is prior authorized, or if they were placed on a wait list. Support coordinators should send referrals to the LDH PAL if the SC has not received an approval within 60 days from the choice of provider date and the MCO was unable to resolve the issue. If you submitted a referral to Medicaid Managed Care case management and the MCO was unable to resolve the below issue within 10 days of the referral. So if the previous PA expired, if the SC has been unable to find a willing provider, or the provider is not providing the amount of services as prior authorized or at the times requested. If the PAL referral is sent to LDH for an MCO member, LDH will forward the referral to the MCO requesting notification upon resolution. And all questions regarding Medicaid Managed Care Program PAL procedures should be filtered through me, and that's SRI's phone number and my email address to forward to LDH. Issues with Medicaid Managed Care Program communication process should be filtered through me, and I'll share them with LDH. So any questions specific to Medicaid Managed Care? All right, so now we're going to talk about post-public health emergency. The COVID-19 public health emergency ended on May 11th, 2023. The state filed an extension with the Centers for Medicare and Medicaid Services and the state's state plan amendment for both targeted case management services of the new opportunities waiver and the early and periodic screening, diagnostic, and treatment services to extend the ability for SCs to complete virtual visits in lieu of face-to-face visits. This extension ended on November 11th. A permanent state plan amendment has been approved with an effective date of November 12th, 2023. The role of the support coordinator is to understand these processes for documentation purposes and to help participants and families understand when virtual technology is able to be used. Okay, so a permanent state plan amendment has been approved to allow 2 quarterly visits that are not the initial or annual plan of care visit to be conducted virtually when the following conditions are met. The beneficiary family is in agreement that a virtual visit is in the best interest of the beneficiary. The support coordinator is in agreement that a virtual visit is in the best interest. The provider agencies are in agreement that a virtual visit is in the best interest. The legally responsible individual or family members living in the home are not paid caregivers. Technology is available to complete the visit with direct observation of the beneficiary and the home. And there's evidence that the requirements for the quarterly visit can be completed virtually. The following criteria must be met. So it must be initiated by the participant family. So they're the ones that requested the virtual visit. The participant and the support coordinator must have a device with a camera, format capabilities, and internet services necessary to complete a virtual visit that includes the ability for the SC to view the home and participant in order to complete the observation required. And the participant family understands how to utilize the virtual format. So the beneficiary and the legal guardian have to be present to complete a quarterly visit, so you need to be able to see that they're present. Participant and family understands HIPAA requirements for the use of a virtual format, and you must be able to obtain electronic signatures using a HIPAA protected platform for electronic signature. Okay, so categories where quarterly visits are not allowed. If it's an initial plan of care assessment, that's going to be completed in the home and face-to-face. If it's an annual plan of care assessment, it must be completed in the home and face-to-face. And then you must have at least 1 quarterly visit per calendar year will occur face-to-face. And again, if it's just a regular quarterly visit, that can be at any location of the beneficiary's choosing. Those do not have to be in the home. Okay, and then this is just an example. I pulled someone whose CPOC dates were 11/10/23 to 11/9/24. So their annual CPOC meeting could be completed anytime from 8/11/24 through 10/4/24. So looking at the calendar year ahead, you could hold your in-person quarterly the first quarter, a telehealth visit the second quarter, and then you could complete your annual plan of care meeting, which is also going to be in person the third quarter, which would allow you to do 1 more telehealth visit the fourth quarter of the year. Signing of documents, acceptable signatures include original hard signatures are required for initial annual CPOC assessments and any face-to-face quarterly reassessments. And then HIPAA protected platform for electronic signature for any virtual quarterly reassessments. For electronic signatures, the participant family is able to and agrees to use the electronic signature option, and the agency using electronic options accepts responsibility to assure compliance with all federal regulations for retention. Anytime a participant or family says they want to view or sign a plan of care in person, this must be accommodated and no verbal signatures are allowed. And then we're going to go over how you would code the different kinds of visits. So the LSIS codes that would be used for a telehealth quarterly reassessment. So place of service is going to be where you, the support coordinator, are. So you're either going to be at your office, which is a 13, or you're going to be at 99, another location that is HIPAA compliant. The type of contact, you're going to use 08 telehealth. And again, you can use a maximum of 2 telehealth quarterly visits per calendar year. Your service activity would be just a 53 reassessment. And then service participant, the recipient has to be present and the parent or legal guardian must be present. If the beneficiary is a minor, is legally interdicted, or is a competent major that cannot direct their own care. And then you would also code anyone else present at the meeting. And then the codes for face-to-face quarterly reassessments, the place of service is wherever the beneficiary wanted to have the meeting. So it could be the participant's home, the participant's school, support coordination agency, etc. Your type of contact is going to be 01 for face-to-face, and a reminder that you must have at least 1 face-to-face quarterly visit per calendar year. And then same thing with the service activity and service participant. And then your codes for an initial CPOC meeting, that's going to be at the participant's home and face-to-face. And the service activity is 52 initial assessment. And then ELSIS codes for annual CPOC, again, in the home, face-to-face, and you're going to use service activity code 54. Okay, and then I know this is real tiny, but our programmer was able to have the new quarterly review form go live this morning. So if you open up, like if you click the button to add a new CPOC and you're doing an initial or an annual or an interim, you're gonna have access to the new quarterly review form. So when you go to print out a new plan of care, it'll have this on there. So I made a few changes to like the questions that we asked, just so that it, matches up with the handbook and like the PowerPoint presentation. So you've still got your current status, all those are the same. And then I've got review of the following occurred, and it just has all the different appendices that y'all are going to go over with the. Okay, and then participant questions, that pretty much remained the same. And then you've got your regular notes box and documentation of who was present at your quarterly meeting. And at the very bottom of the form, if this is one of your virtual visits that you're doing, you're going to document that all of the criteria were met. So the beneficiary requested it, the support coordinator agreed to it, the provider agency agreed to it if applicable, and like you have the technology available and all that stuff. So if you're doing your visit via telehealth, you would open up your interim CPOC, complete the virtual visit attestation, and then your service log would document that it was completed via telehealth, and that the beneficiary requested it and how you completed that meeting. Okay, support coordinators are allowed to utilize telehealth in place of 2 face-to-face quarterly reassessments that are not the initial annual CPOC. The beneficiary and the legal guardian must be present to conduct an initial or annual CPOC or a quarterly visit. Telehealth must be used if you're completing it virtually. If the beneficiary does not have access to Skype, FaceTime, Google Meet, etc., the visit must be completed face-to-face. Okay, so any questions about that new information? So it would just be if the family, so the question was, one of the requirements is that this is right here, number 3, the provider agencies are in agreement that a virtual visit is in the best interest of the beneficiary. So if the beneficiary wanted their provider agency to come to their meeting, like a PCS provider, that provider would need to agree to it. But with EPSDT, it's optional for the provider to come. So if the beneficiary doesn't request it, then that just wouldn't apply. Mhm. Yes. Okay, so the question was about EPSDT personal care services who can act as a staff member. And then also that some provider agencies are giving families bad information. Okay, so you can always refer everyone to LDH Informational Bulletin 23-5, and it explains there's like a link, or they can click to the EPSDT PCS provider requirements, and then it clearly tells you what staff is not allowed to be a worker. So staff assigned to provide personal care services shall not be a member of the recipient's immediate family. Immediate family includes father, mother, sister, brother, spouse, child, grandparent, in-law, or any individual acting as a parent or guardian of the recipient. Personal care services may be provided by a person of a degree of relationship to the recipient other than immediate family if the relative is not living in the recipient's home, or if he or she is living in the recipient's home solely because his or her presence is necessitated by the amount of care required by the participant. So again, immediate family, parents, siblings, grandparents, or in-laws. So it could be a mother-in-law, sister-in-law, grandparent-in-law. It can be a person of a degree of relationship other than immediate family, like aunts, uncles, cousins, as long as they don't live in the home, or they live in the home because it's necessitated by the amount of care that the recipient needs. And again, all of this information can be found on Informational Bulletin 23-5 or in the EPSDT PCS provider requirements. Yes. Okay, so she's asking about EPSDT personal care services, the number of hours that can be approved. So there is no set limit on the number of hours. It's whatever is deemed medically necessary. So you'll get the Form 90, the physician or medical person is going to fill that out, and they're going to be prescribed like a certain number per day. So it can't exceed whatever is deemed medically necessary. So if they're approved for 3 hours a day, they would get 3 every day.
And we didn't put as much information as possible because doctor looks at that and then more fancy of the documentation is not there, and there's no way to support that it should go out.
And I'll include the answers to all these in the questions and answers that I send out as well.
If you schedule the visit in advance, can you mail the signature things to the family prior to the meeting?
I think it has to be because you want it completed like at the time.
So like if you see them like physically fill it out at the time of the meeting, and you know, okay.
Let me check on that.
Okay.
Any other questions? Yes, we have to. You have any questions online?
Oh, it's like showing that.
Okay, well, it does not look like there's any questions on the chat. If y'all need to contact me, my name is Tracy Barker. My email is Tracy, TRACY .Barker, the number 2 at LA.gov. If you don't put the 2, it's not coming to me because there's another person with my name. And my phone number is 225-342-8156. Phone number, 225-342-8156. Not with the contact, so I have. So, yeah, any questions about that, or anything, Medicaid policy wise? Any other questions? All right, thank y'all.
Thank you.